Greeting, this is Ron for the Encyclopedia team. It is with great pleasure we have Dr. Ghassan Abou-Alfa joining us for this interview. Thank you very much for coming.
Thank you so much, Mr. Wang. It's so nice to see you again, and thank you very much for the invitation.
So, Dr. Abou-Alfa, before we dive in, our audiences would love to get to know you a bit better. Can you tell us a little bit about your background?
Thank you so much. So my name is Ghassan Abou-Alfa, exactly as you beautifully said it. I'm a medical oncologist. I work at Memorial Sloan Kettering Cancer Center, where I'm greeting you from, and I subspecialize in GI or gastrointestinal cancer, and I subspecialize into liver and bile ducts and fibromedullary carcinoma. I have been at Memorial Sloan Kettering for the last close to 22 years now. And before that, I did all of my subspecialty trainings and specialty training at Yale University. And originally, I'm from Lebanon. I'm from Asia, and where I graduated from the American University of Beirut, where I continue to be in great contact with your alma mater, my alma mater. And always a message for all colleagues: always make sure you take care and connect with your alma mater. Very important.
I'm sure the journal will continue to be doing well with the help of people like you. So let's move to the main focus of this interview. What makes you want to research liver cancer? And could you please provide a little bit more story of development treatments for liver cancer?
Your question, Mr. Wang, is really divided in two parts, and one of them is really a, a critical one in regard to where we are in regard to disease. But before we get there, let's tell you how I got to cancer, exactly as you asked, or how I got to liver cancer. Funny enough, it's a little bit of a light story, but it's a wonderful story. I came to my interviews for the job almost 22 years ago now at Memorial Sloan Kettering. And after I was offered the job and I accepted, and where I became a full professor now, my boss at that time, or the head of the gastrointestinal cancer, Dr. David Kelson, emailed me. Believe it or not, there was emails 22 years ago. So emailed me and said, would you like to do gastric cancer or liver cancer? And it was a Monday. I reflected on the question for 3 days. And by Thursday, I was fully convinced I have to do gastric cancer. It's very important. It's so common worldwide. It's very critical. And I emailed saying, I'd like to do gastric cancer. He said, well, sorry, but the other colleague of yours that we also accepted for the job took gastric cancer. You'll do liver cancer. And I always say this in a light mood because jokingly, I always tell all of my dear colleagues, and especially our young colleagues, please take your time to answer the question, reflect on it, because I say jokingly, this is the best reflection I ever did. Because I came into the field of liver cancer, literally, there was no therapy for liver cancer. If you recall, doxorubicin was tried, attempted, but it did not work. And the median survival for patients with liver cancer was only 3 months. We did probably the first study ever on sorafenib that led to ultimately the phase 3 clinical trial of sorafenib. And we kind of carried on from Memorial Sloan Kettering with many other attempts of therapies. Proudly, we got many of them to the FDA, either because we led the effort or we were part of the effort. And if anything, we continued evolving the median survival enough that now, as we all know, is close to 20 months. And part of that, of course, proudly, we were the first to really show that the combination of two immunotherapies, being a anti-CTLA-4 plus anti-PD-L1, referring specifically to the tremelimumab plus durvalumab, showed a critical improvement in survival. So proudly, part of that whole story from day zero till now definitely is very appealing. And of course, there's nothing more delightful than to see patients in the clinic, thankfully, doing way better with liver cancer treatments.
Totally. And I like how you remember the exact date of how you get into liver cancer. So could you please briefly introduce the global access to the therapy for liver cancer?
Thank you so much, Mr. Wang. And this is what I, again, always delighted to see the globality of the questions that you bring in, and as we spoke about the globality of the journal Cancers as well. As we know, liver cancer is truly a global disease. We know very well that a high incidence continue to occur, especially in Southeast Asia, including China, South Korea, and many other places. And number two is it also occur with high incidence in the continent of Africa. Uh, and of course, in the Western Hemisphere, it continues to grow. And the reason is because there are four key risk factors that lead to liver cancer, and some of them are way more common in some parts of the world, like, for example, hepatitis B in Asia, hepatitis B in Africa, as well as hepatitis C more in the Western Hemisphere. The new advent in the Western Hemisphere is the non-alcoholic steatohepatitis, which is really led off by the fatty liver disease because of morbid obesity and diabetes. Now, as we all know, and this is really the important component, we have to take care of the disease wherever it is, wherever it might be, because sadly, as we know, access to therapies is based on ultimately what is the access economically that will permit that to happen. I'm really astounded and amazed that our colleagues, for example, in Africa, that whom we worked with very collaboratively, and were able to produce ample amount of data that we published and reported at what's called the aortic meeting, or the Africa Oncology Research Group meeting. It's amazing that from 500 physicians, we're able to find out that, yes, they have amazing knowledge in regard to treatment of liver cancer, but they don't have access to drugs. Believe it or not, 84% of the physicians in Africa, they only have access to sorafenib. That's all that they have access to. So we have a great, important message to all of us to make sure that we work together to ensure that one day, hopefully, we'll be able to ensure that every patient with liver cancer, wherever they are in the world, are getting treated.
Fantastic to hear that you as a team are working globally. So our next question is very specific. So fibrolamellar cancer, also known as FLC, is a rare liver cancer that usually affects adolescents and young adults. It is different from the main form of hepatocellular carcinoma in several ways. Could you talk more about the rare fibrolamellar cancer, not limited to symptom, diagnosis, treatments, etc.?
Well, thanks so much, Wag. Again, one more delight to kind of like have an interview with you, because you hit on a very dear subject, because we really have to take care of our dear dear patients who have fibrolamellar carcinoma. They are no doubt, as you said, young. The median age is like 2030s. Number two is a little bit more women than men, but more importantly, it's uncommon. We do see it, but at least some data suggest that there's only about 200 patients with it, fibrolamellar carcinoma worldwide. I guess it might be a little bit more than that, simply because it's not like everybody has access to even diagnose it per se. With this said, why does it happen? We don't know. There are some theoretical potential pockets where there's more fibrolamellar carcinoma than other compared to other places in the world. We're not sure if it's true, but nonetheless, interestingly, one of them could be Shanghai, but we're not really sure, and they cannot really say to that, short of some observations noted by our colleagues. But more importantly, because of the rarity of fibrolamellar carcinoma, the efforts to try to get a drug that's applicable for them or do clinical trial for them is almost unheard of. So we really go out of our way, and really a great thanks for many entities that helped us in developing that, among which number one is the first effort ever we did was with an organization called the Fabulary Carcinoma Foundation. It's a foundation, nonprofit, to help patients with liver cancer with fibrolamellar carcinoma. And if anything, they sponsored and supported the first trial that we published, which sadly was negative, but at least it was an attempt. After that, we start working with companies, explaining to them that it's an important part of their asset to make sure that they look into fibrolamellar carcinoma. And proudly and smartly, some of them did, among which a company from China. We did a study on what's called the NMET 2076, it's an oral kinase. We did another study on a anti-HER2, and currently and proudly, we are doing a study on a double checkpoint inhibitor one more time in fibrosing carcinoma, and we give a lot of credit for the sponsor of that study as well. Add to this, it's very important to really understand why the disease happened. And for that, we actually have a registry that we're building along with our colleagues literally worldwide, that will provide access to the patients to really provide information to us to really understand anything that can really make us better realize why do they get fibrosing carcinoma. And the nice thing about that registry is that patients don't need to be our patients. They can be anywhere in the world and can be done even from a mobile phone. And of course, we are always accessible to help guide our colleagues and of course our patients to access that registry. But more importantly, the clinical trial, yes, is on, and yes, it's accruing, and definitely it's open to all patients wherever they are in the world if they can make it, of course, to one of the sites that has the study, which is mainly based in the US.
Very interesting. So cancer itself can be passed down from parents to children, and genetic changes in tumor cells can be passed down. But a genetic change that increases the risk of cancer can be passed down if it is present in a parent's egg or sperm cells. Would you like to share your opinions on genetic inheritance of cancer?
By all means, it's a great kind of transition from the previous question, because to be fair, we don't know yet, specific to end on the family number, we don't know if it is inherited. To be fair, we're not implying that. But now you're talking about a totally different issue in regard to what we call a germline inheritance. In other words, this is genetics that really passed on, as you said, from one generation to the other in the family, and it can be passed on others from mother or father to child. It could be also passed on from grandparents to child, etc. Interestingly, there's a good understanding that these are better understood, and we are realizing that they are even more common in many parts of the world. A good example of this is BRCA, a genetic alteration or mutation that can cause mainly breast cancer, but can cause other cancers as well. Now we realize that even though most of the robust efforts have been done in the Ashkenazi Jewish populations, but then we know that BRCA is noted almost in every population in the world. Maybe it's different commonality, but still present. And of course, there's more kind of genetic alterations that can occur in different populations as well. The amazing thing, and this is like message number one, we are proving that we are all one people after all. We are all one big family. And if anything, we have to really make sure that we take care of our patients with the germline inheritance of cancer. What's fascinating to us, and this is an effort that we have done at Sloan Kettering, no doubt that the convergence of populations can lead to certain enhancers or changers in regard to genetic inheritance. A good example of this could be, for example, in Singapore, where you kind of have two wonderful populations that decided to live together, being the Chinese and the Malay, and now there's actually intermarriages happening. That convergence can lead, of course, to certain germline inheritance. On the other hand, sadly but understandably, there's divergence of populations where patients and or families are separated because of many reasons, among which wars, conflicts, diplomatic or rather political conflicts, immigration, you name it. Even it could be economic, and this can lead to certain stressors onto the genetic makeup of the cancers. We proudly, beginning of the year, we went ahead and invited 72 of our colleagues from 36 countries. Many of them are in conflict, and proudly were able to really learn together what can we do to make sure that we have a better understanding of genetic inheritance. Because our biggest concern is, as the populations diverge or converge, are we changing what we think we know to something that really can evolve into a more valuable information to treat them correctly. So it's work ongoing. Proudly, China was there, and many other countries in the world were there, and hopefully we'll continue to do the work together to really do what's best for humanity, no matter what it is.
I totally agree that we are one big family after all. So before we finish, is there any acknowledgement you would like to make?
Well, I can't thank you enough, Mr. Wang. As always, a great question, great interaction. As you see, we're both enthusiastic about what we're talking about. A big thanks for MDPI, a big thanks for cancers and all what they do. And of course, a great thanks and great wishes for all our colleagues who are listening in. And always nice to interact with all of you. And hope to see you in China in person one day.
Pleasure is mine. We wish you and your team the best of luck on your future research, and thank you again for joining us.
Thank you so much, Ms. Wang. Thank you.